join this fine group. And I am looking forward to addressing some of these issues. Of course, a lot of the work done by Dr. Edward Chow and his group have been extremely informative, including a lot of work done with radiation-induced nausea and vomiting, which I will not really be addressing. I'm going to be talking mainly about chemotherapy-induced emesis during this talk, although there'll be a few other issues, and I hope that we'll have some good questions. These are my conflicts. I want to thank the folks from Knight Pharmaceuticals for making it possible for this presentation. And most of my funding over the past many years has come from National Institutes of Health grants. So we are at an extremely exciting and interesting time in oncology. We have these three basic approaches to most advanced cancers, and we even use them in many instances in adjuvant and preoperative chemotherapy strategies. Really, the question is not which one of these is best. The question is, how do we use these together? When do we use them as single entities? When do we use them as combinations? So our molecularly targeted approaches address mechanisms of carcinogenesis, cell growth, and particularly signaling. With our checkpoint strategies in immune oncology, we have mechanisms of metastasis and avoidance of immune surveillance. And with chemotherapy, we have more of an approach that generally goes directly to DNA. These really are different. They can be complementary, but we don't need to use them at all of them at all times. Chemotherapy remains a very important part of oncology, so supportive care is really important as well. Which is more important, quality of life or length of life? I think it's a false question. Our patients would like both, and we would like to achieve both of them for them. And so how do we get the best quality of survival and the best survival possible? And that really is where supportive care comes in. I like to think of the definition of supportive care as basically our approach to cancer other than the treatment. That's important as well, but there are so many different areas where patients need support and where we can do so much better to affect not only quality of life, but as many studies have shown, survival as well. Now, these are some of the many roles of supportive care, but the classical roles are the three that we see on this slide. It can include end-of-life care, preservation of quality of life, and symptom and side effect control. These are kind of traditional roles of supportive care, and I think they fully deserve all of our attention to get the best possible outcomes for our patients. Now, this is just a partial list of some of the side effects and avoiding some of the side effects. We're going to be talking about emesis today. We have pretty good prevention, not so much treatment, but pretty good prevention of emesis related to chemotherapy. But of course, there are many side effects that we have to pay attention to. Many of these are different than they used to be a few years ago. Indeed, pulmonary toxicity has always been an issue with chemotherapy, but with our molecularly targeted agents and with our immune checkpoint inhibitors, these can be more threatening and more of an issue. Same thing with skin toxicities. We see more dermatologists helping us with some of the side effects of some of our treatments. So we have a lot of work, but since emesis is something we have to ask about and think about for every patient receiving chemotherapy as well as targeted agents, and in some of our newer agents that combine antibodies as well, these are increasingly important issues. So I'd like to go over a few clinical aspects of emesis before, which I think we can all accept. This is a study that was done using an instrument that looks at quality of life or impacts on daily living, whether patients have emesis or not. And in the left-hand set of bars, the gray bars show the quality of life that in a score 115 that patients expressed immediately before chemotherapy. And then if they had, in the left-hand set of bars, emesis, the immediate fall of 1/3 fall off if they had emesis of how patients 3 days later rated their quality of life. If we see our patients who did not have emesis, then 3 days later, there has been the right-hand set of bars and the green bar, no change in quality of life. So this is a very large impact on quality of life, simply depending on whether or not patients had complete control or not of their chemotherapy-induced emesis. Another issue came out, and this was repeated in several other studies, looking at our perceptions of how our patients are doing, especially since we know that having emesis has such an impact on quality of life. So there's acute nausea and acute vomiting, acute being defined as the first 24 hours. The blue bars are what the doctors and nurses rated the percentage of patients who would have problems with acute nausea or acute vomiting, and the green bars are what the patients really experienced. So in the first 24 hours, we did pretty good in that we are corresponding to what the patient said. But for delayed nausea, delayed vomiting, that which occurred more than a day later, peaking usually at 48 to 72 hours, there was twice as much delayed nausea, twice as much delayed vomiting reported by our patients than we perceive that our patients would have. So the idea of using the very best antiemetics in the appropriate setting as prevention from the first cycle on, not wait until patients have problems, is really clear. We know clinically that the most important factor is what chemotherapy are you giving. Lots of charts exist to show whether chemotherapy is of low risk, moderate risk, or high risk, and which regimens are so associated. We know it is more difficult to control emesis in women than in men. We know it is more difficult to control emesis in younger patients. And for some reason, and we can talk about it, patients who have a long and strong alcohol intake history are easier to control. This has nothing to do with whether people are taking alcohol at present. It has to do with their past history. We talk about molecularly targeted therapy for cancer. Nothing is more molecularly targeted than our antiemetic approaches. We know which pathways or expressions are important. We know which ones are activating pathways. We understand the mechanisms, and we have agents, drugs that affect these mechanisms in these activating pathways. So the control of emesis is very scientific and very molecularly seen. If we look at it anatomically in terms of the physiology or neuropharmacology of emesis, this is not pathophysiology. This is the real physiology that people have. Of course, there are important receptors in the gut. There would be for emesis when you think about it. And the enterochromaffin cells in the upper GI tract contain a very large amount of the body's serotonin. Immediately adjacent to them are vagal nerve afferents. So you can cause emesis by direct problems in the gut, or these vagal nerve afferents send the signal into the brainstem, and there is located in the floor of the fourth ventricle, not blocked by the blood-brain barrier, the chemoreceptor trigger zone, which is rich with neurotransmitter receptors, especially the 5-hydroxytryptamine or serotonin type 3 receptors and NK1 receptors. That message can then go further into the brain, which coordinates the very difficult actions that are associated with vomiting. Now, These are neurotransmitter receptors that are considered to be important in a whole variety of areas: seizure control, depression, anxiety, a whole variety of different areas. The ones that are the orange to brownish are the ones that appear to be the most important activating receptors in terms of emesis. So we have the serotonin receptor. There are at least a dozen serotonin receptors, but the type 3 appears to be the one that is most involved with emesis. And we have substance P, the NK1 receptor antagonist, for which the natural ligand is substance P. NK1 is the natural ligand for substance P. These are highly selective receptors, and we have antiemetics that are targeted very selectively for these receptors. Now, highly selective means 1,000 to 1 or greater activity for these agents, these antiemetics that work at these receptors that we use commonly clinically, 1,000 to 1 for these receptors over other receptors, or even more so. This means that not only are they effective, but they have few side effects because there's few off-target effects. Now, we have a couple of other useful antiemetics, and those are corticosteroids, and more recently, the antipsychotic drug olanzapine. Now, these drugs are useful, and we'll be talking quite a bit about them, but they have off-target side effects. All of us could name a variety of off-target side effects for corticosteroids, from sleeplessness to edema, to even to elevating glucose, etc. These are off-target side effects. So really, I believe that we should have evolved to the point that we want to emphasize the highly selective agents that are not only effective but minimize side effects, and use as little but the best amount of the less targeted ones to minimize side effects while maintaining efficacy. So what's relatively new over the past few years? And here's a list, and I'd like to look first at some of the newer agents. Why do we need newer agents? And the reason is, while we have some pretty good drugs these days, they're not always used as effectively as they should be. And they're not always prescribed or even taken. So when we give medicines for delayed emesis over multiple days, we find that many patients do not adhere to that schedule. They have an awful lot on their minds. And unfortunately, oncologists often do not prescribe guideline-indicated evidence-based agents. The idea came about, wait a minute, wouldn't a way to make this as easy as possible to have an all-oral regimen, have just single dosing right before the chemotherapy? We're all done. Nothing more for the patient to learn, if that can be fully effective. And I'd like to see how we're doing with that. Now, when we talk about new agents, I'm looking at these 4 in particular. I'm not going to talk about Relapitant because it isn't really available in most countries these days due to some toxicity issues. It's kind of interesting, but it's really kind of an inside baseball idea now. What about cannabinoids? THC, inhalant marijuana. Why aren't they recommended by most guidelines? Well, it's because of side effect issues and low efficacy. I know that in Canada, you all know a lot about cannabinoids, and especially in Ontario, and they're more available. New York State is following in your lead, to the point that, of course, we haven't changed our flag, but, you know, I've heard it said maybe this should be a new model of the Canadian maple leaf flag. Maybe not. But what is the data? Well, these are some old studies I'm going to show you, but still, in patients given cisplatin, it's not the only emetic agent, but it causes emesis in everyone. So it's quite a good model to use. An obsolete treatment was high-dose metoclopramide. which didn't just work in dopamine receptors, but also worked in 5-HT3. And if we look at the complete control in a randomized trial, what we can see is what was a significant difference where THC, delta-9 tetrahydrocannabinol, felt to be the active ingredient in marijuana, had a much lower efficacy. It had some than metoclopramide in very high doses, and that's an obsolete treatment, and that's where THC was. Now, there was a Canadian study that was quite interesting, conducted in Alberta by Martin Levitt many years ago, but the design's sort of interesting. He randomized patients getting chemotherapy to a crossover study. It was blinded, and they received either inhalant marijuana plus a dummy pill or oral THC plus a dummy cigarette. And then in the next cycle, they were crossed over. The endpoint was, which did you prefer? The winner was no preference. Why was it nobody preferred the inhalant marijuana with all the ingredients over oral THC? And if you look down in the bottom there, you can see that the control of vomiting was only 25%, of nausea even less. And so, of course, there was no preference. It's not very effective. It's not totally ineffective, but it doesn't compete with our newer drugs. Olanzapine, we hear a lot about it these days. It has some value. It's the non-selective, non-specific neuroleptic, so it hits many neurotransmitters. We have questions of the schedule, of the dose, and we have some side effects, especially sedation. A lot of the trials have been troubled by methodologic issues, but nonetheless, there's no question that it can be useful. Again, it hits a bunch of neurotransmitters. If you needed that one to be blocked, that would be great. But if you didn't, then you might be in line for some side effects, including sedation as an issue. So what's its role? Adding it as the fourth drug in a combination to steroids, 5-HT3 and NK1. Do you use it as a rescue for patients who didn't do well before? What's the dose? 10 milligrams, 5 milligrams? What's the schedule? Most of the studies recently have only been done for 4 days. So we don't even know if more or less would be useful. Nonetheless, it's found its way right into the guidelines. So I would summarize its efficacy as the fact that there is good evidence that it's truly an antiemetic, including in a phase 3 trial. But there's only moderate evidence as to what dose should be used, either 10 milligrams or 5 milligrams. But the problem with the studies that compare these is that they're far too small to be able to detect whether there's an advantage to one or the other dose. And the evidence for the schedule of 4 days is very arbitrary. Why not 1 day, 2 days, 5 days? We don't know. And I think that's a real problem, and there should be more attention about that. There's no doubt I use it as a rescue medicine, and there's a lot of evidence to say that in certain settings, as a fourth drug in a combination, it adds value. The dilemma is the side effects, such as sedation, versus the efficacy. Some people have quite a bit of sedation from it, and it can interfere with their activities of daily living. I like to give it at bedtime. And if you use it at bedtime and the person's gotten steroids on the day of chemotherapy, that's when I give it most. It might even have value for that use. But I don't, especially in older patients, like to continue it for multiple days unless there's a really good reason. So you can see sort of the way I use it, but this is just opinion. And that's considered to be the lowest level of evidence, which it should be. So in the lowest risk group, older men, I give it just once. In younger patients or women, I give it for 2 or 3 days at a lower dose. And if they did well, I might eliminate one dose. This paper was sort of interesting. It's not for chemotherapy-induced emesis, but they gave for patients with cancer with other reasons for having emesis, and that could be a whole variety. They gave the olanzapine at just 5 milligrams a day for 7 days, not much. And all of the endpoints they looked at showed advantages for giving the olanzapine, including adding more drug or the patient's perception of their well-being. So I think it's useful information, and that's something that I do in my practice also. Now, the last group is interesting, and that's NEPA. That's the combination of NE, nitupetant, plus palonosetron. So it's an NK1 and palonosetron, both combined, a fixed dose. It's a single oral dose, and we have a lot of information on it and a lot of real-world activity. So again, single, all oral in one capsule. Palonosetron is specifically recommended in some antiemetic settings by some groups, and it appears not to prolong QTc intervals, which is attractive for many. Palonosetron has the longest half-life in the plasma of any of the 5-HT3 antagonists, and nitupetant has the longest half-life of any of the NK1 receptors. Well, how do you decide on the dose in these combination studies? There were studies looking at oral palonosetron that showed numerically better results at 0.5 milligrams. But what about adding the NK1? This was done in a really sophisticated way by using brain PET scans. And it turns out, if you look at the right at the actual scans, you can see the SUV, the standard uptake values, and the hotter colors, the red and the yellows, show what the blockage at a lack of blockage, but for detecting NK1. But you can see all the way out to 96 hours, the lower right, you still get a cold scan. The blockage is continuing, and that was achieved quite well at the 300 milligram dose, which was better than the 100 milligram dose to get that kind of blockage, but and very similar to the 450. So that was decided for NEPA to go forward, was 300 milligrams of nitupetant plus the 0.5 of palonosetron. A very interesting study was this large one done in the difficult setting, women with breast cancer getting anthracycline cyclophosphamide, almost 1,500 patients. One group, the orange group, got just palo plus dexamethasone, only one dose, and the green group got 3 drugs, that is the NEPA, nitupetant, NK1, palonosetron, and oral dex. Well, if palo can work better palonosetron than the older 5-HT3 antagonists, do you really still need to add this? Do you get benefit by adding the NK1? This was also very modern because the patients only got this single day on the right before the chemotherapy and no other antiemetics at any time. So looking at the results, there was a little bit of an effect in acute emesis. Because it's such a large trial, it was significant, and there was benefit in delayed emesis and an overall. And in fact, these results are really extremely good results in this setting, and it's a little bit more than a 10% overall advantage, and you do need to add the NK1, the nitupetant, if you're going to get the best possible results for your patients. They looked also at no significant nausea. There was some better control of nausea, and this lasted over 4 cycles, which were the 4 that they mentioned, that they measured. So there was another study done looking at the safety of giving multiple cycles, and this is in patients receiving cisplatin, anthracycline, cyclophosphamide, and moderately emetic. Was it safe? And was it effective over multiple cycles? Because after all, we never intend to treat somebody with just 1 cycle of chemotherapy. It was controlled. Everybody got palonosetron. Half of the patients were randomly assigned to nitupetant, so that's the NEPA group in purple, and then half got aprepitant. So the only side effects that would have been seen would have been attributed to the selection of the NK1. There were no safety signals, no cardiac signals, no safety signals, the usual headache and constipation that are seen with the serotonin antagonists. The NK1s have very few side effects, and you can see that the efficacy was maintained over multiple cycles and always gave numerical favoring of the nitupetant combination. So that raised a few questions. Can we give the NEPA, nitupetant palinositron combination, on just one day as it's supposed to be given? And how does that compare with 3 days of giving aprepitant, the other very used NK1 receptor antagonist? So the study design is seen here. Everybody in the NEPA arm got dexamethasone, 12 milligrams, the lighter blue group here on the left, got dex on day 1 and then dex for 3 more days. And they got a single NEPA combination capsule, the nitupetant NK1 plus the palinositron 5-HT3 antagonist. And if you look at the aprepitant regimen, it differs primarily by how many days of aprepitant they got. So they got 3 days versus just the 1 day of the NK1 in the NEPA group. Well, would you still be able to control delayed emesis with this? Again, the dex is the same, and it was the choice of the NK1 of the serotonin antagonist by the investigators. And this is the result of, these are based on 3 studies, 1,200 patients altogether. And if you look at delayed emesis, it's very similar to slightly numerically favoring or statistically favoring the NEPA group for delayed emesis, even though they only got 1 day of an NK1. But if you look more closely at delayed emesis, not just all 4 days, it's pretty interesting to see that the green bars, the percent of patients who had breakthrough nausea and vomiting by days 2, 3, and 4 is actually less. And this is significantly less. So even the 1 day of the NK1, just as those PET scans showed, continued to occupy the receptors and give good and improved clinical results. So we've talked about cannabinoid use, we've talked about olanzapine's role in some of the questions, but who should be getting NK1s? And I think if you look at these 7,500 patients in 13 large randomized clinical trials, all phase 3 trials, we can see with cisplatin, where almost everybody accepts that an NK1 should be added, that there is benefit. It is an absolute benefit of 16%. So you only need 6 patients to treat for 1 to benefit. That's a very low number needed to treat in oncology. Well, carboplatin is less used here, but notice the absolute benefit is nearly the same. And for anthracycline cyclophosphamide, used in a whole variety of malignancies and, of course, breast cancer, the magnitude's about the same. So I believe if we accept the use of NK1s in people with cisplatin, we surely should do it in carboplatin and people getting AC as well. If we look then just at carboplatin, I put together these 5 randomized trials, and what you can see is the control of emesis, either by complete response or no emesis rate, with 3 drugs in the first numerical column. And then in the middle numerical column, you see if they only got a serotonin antagonist and dexamethasone. In every instance, there is an absolute benefit very similar to the benefit seen with cisplatin. And if you look at the 2 studies by the arrows, those were done in GYN Oncology. And so if you look at the control rate then just in women in these, actually only half or fewer patients would be free of emesis, and that there is significant improvement if we add the NK1. In fact, If we fail to give the NK1, the rate of emesis with carboplatin would be worse than it is with cisplatin. So most of the guideline groups have incorporated NK1 with carboplatin as well as with cisplatin. Now, I'd like to talk about corticosteroids. This remains controversial, but I think there's a lot of evidence that should guide us, evidence beyond the guidelines. Can just 1 day of dexamethasone give results as good or better than multiple day dexamethasone regimens? And what happens to toxicity rates as well? This looks at 5 studies that was presented a few years ago. It's 1,100 patients altogether, and they're either getting dexamethasone just on the day of chemotherapy, or they're getting 3 or 4 days of dexamethasone, all randomized. And these are the results in a forest plot. You can see that the results, whether patients got 3 days of steroids or just 1 day of steroids, are extremely similar in each one of these trials. And the diamond overall result is right there being the same. Now, these are in patients getting anthracycline cyclophosphamide and other moderately emetic. It's not with cisplatin. Only more recently have we had cisplatin results. This is a Japanese study. This is a Japanese study with 400 patients. 2/3 are getting anthracycline cyclophosphamide. 1/3 are getting cisplatin. The middle column are the results of control for those endpoints of day 1 only dex, and the right-hand column for 3 days of dex. As you can see, for acute emesis, for delayed emesis, the results are extremely similar. And this, again, was the first cisplatin kind of information we had. Since then, there's been a trial with oral NEPA, and it looks at dexamethasone minimizing regimens again, and there are 3 regimens that are used. So there's a dex 1 for 1 day arm, there's a dex 3 days of dex, and a dex 4 arm. Everybody got oral NEPA, nitupatid palonosetron on day 1, and 12 milligrams. In dex 3, they got 2 more days of dex, and in dex 4, they got 3 more days of dex. And so when they looked at the results of the control of emesis, it is amazing how similar they are. You can see the acute emesis control is 90%. That's great. These are all patients getting cisplatin, and that's the tan-colored bar. And then for delayed emesis, you can see in the dex 1 arm, the dex 3 arm, and the dex 4 arm, delayed emesis or overall control is remarkably similar in all 3 groups. Now, they made 2 mistakes in this trial that are sort of minor. One is their endpoint was non-inferiority, and the other is that they only incorporated 250 patients, so 80 some odd patients per arm. You can see that the results are as close as possible, whether they give 1 day of steroids in these cisplatin-treated patients, 3 or 4 days, but they did not achieve non-inferiority because they didn't have enough patients for that. You probably need 2 or 3 times as many more patients. But these results are remarkable, especially when added to the Japanese results. What about toxicity? So I've combined the 3 days of steroids and 4 days of steroids because the results were just about the same, and looked at these important toxicity characteristics. In no instance was the toxicity worse with 1 day of dexamethasone, but notice in insomnia, it's 1/3 less if they only got 1 day of dex with the same efficacy, and for agitation, it's 1/3 less. With heartburn, not much difference. So you preserve efficacy in this 252 patient trial with basically identical results, but with decreased toxicity. Slightly off the subject, but dexamethasone in surgery. Here in over 8,000 patients, they gave 1 dose of dex right before completing the surgery, and you can see the nausea and vomiting results in these patients were less post-op nausea when they gave Dex. There were no negative endpoints to giving the one dose of Dex. Kind of interesting, perhaps, to share with our surgical colleagues. And again, it was published in the New England Journal. Okay, what about looking at guidelines? Well, guidelines are a very conservative group doing things. They don't like to change easily, but they can help guide us. The problem is we often get opinion as opposed to evidence because they don't want to leave us without covering every situation. But they can help us have effectiveness, what happens in our day-to-day practice, equal efficacy to clinical trials if we can treat patients the way they were in good clinical trials. There are lots of major groups. There are groups in Ontario, as you know well, groups in other provinces as well. But again, groups like NCCN focus on opinion, consensus, rather than evidence, although evidence, of course, influences consensus. But I believe we need to simplify the way we treat to be able to get more patients to adhere and to make it easier to prescribe the best drugs. And if we can simplify, to me, that means one day. So most of the guideline groups look like this, although many of them do not contain this moderately high group, which would be carboplatin, possibly oxaliplatin, and AC. They like to name these after different groups, but I think that this should be added. But you can see for the high and moderately high groups, they give 3 drugs, and more recently have added olanzapine to both of these groups. This is for acute emesis. 2 drugs for moderate and 1 agent for low and nothing for minimal, like the vinca alkaloids, especially vincristine, vinblastine. So this is the way many guidelines look for acute emesis. The difference comes with delayed emesis. If you believe the 1,100 patients who got moderately emetic agents, they don't need to get Dex for delayed emesis, just acute emesis. But that was true for AC and carboplatin also, so they don't need Dex for that group. And if you give a long-acting NK1, such as nitupetant, just on day 1, those patients do as well and don't need further NK1. That leaves us only with the cisplatin controversy with almost 400 patients where the results are very similar. So in my practice, we do not give Dex after day 1. And so that really takes us out of the delayed emesis business. We're treating delayed emesis on the day of chemotherapy, especially accepted by most guideline groups now in AC and carboplatin. And some say yes for cisplatin, others say no. I think there's very sufficient evidence these days for no for cisplatin. If we look at groups like NCCN that make things very complicated, this is a couple of years ago, their chart. For delayed emesis, 1 drug, another drug, 3 drugs, 2 drugs. No, we don't need any in the way that we've been talking when you give something like NEPA and steroids on day 1. So evidence for only 1 day of Dex. So the controversial areas are Dex and olanzapine in guidelines. Over 1,500 patients in 7 large trials, consistent findings supporting similar efficacy for 1 day of Dex versus multiple days, similar efficacy for cisplatin, AC, and less risk agents. Evidence of reduced toxicity, and this evidence is far larger than the trials of 20 and 30 years ago that used multiple days. Olanzapine's useful, but I really wish that they wouldn't accept 4 days, since there's no testing of 1, 2, or 3 days, or testing of more days. So in our practice, we typically use olanzapine just on the night of chemotherapy, that they get chemotherapy that day, and then for higher risk groups, we give a lower dose the next couple of nights. So guidelines need to address economic realities in the world, not just in North America, and decreasing the number of days and making it simpler is less expensive. We need better look at olanzapine and steroid schedules. I think the evidence is there for steroids. For olanzapine, we need more. There's a tension in guideline groups for covering all situations, even though we don't have the evidence, versus strongly evidence-based. And I think this should be clearer in guidelines, maybe color-coded. So again, I think we really believe in evidence-based medicine, not just consensus. The advantages of simplifying antiemetic regimens just one day is better patient adherence, easier for us to prescribe correctly, and easier for patients to adhere so that we have effectiveness more likely to preserve the efficacy. Evidence today supports single agents of serotonin antagonists just one day, and also of the NK1s, especially the long-acting ones. In my view, the evidence is there for single-day dexamethasone versus multiple days, with preservation of efficacy, fewer side effects, and probability of lower cost. The new agents, such as the use of olanzapine, such as the use of NEPA, give us options and make it easier for us to have simpler regimens. The steroids on day one in many settings is quite clear. The delayed emesis simplification of just one day makes it so much easier for patients, allows them to concentrate on other issues like diarrhea, like febrile neutropenia, et cetera. And single-dose NEPA really helps us address these. So I think the guideline committees should look at this carefully, and I think that these need to be options for us for just single-day antiemetics. To conclude, there are many roles for supportive care in cancer, including side effects and preservation of quality of life, of which the best antiemetic usage is there. I really like this statement by Dr. Harold Varmus, the Nobel Prize laureate, the former chief of the National Cancer Institute, who 10 years ago said cancer patients are living longer and better lives thanks to better symptom control, more effective therapies, and a deeper understanding of cancer. I think he really hit it on the nail over a decade ago. So thank you again. I'll look forward to some questions. It's really a pleasure to speak with you, and thank you again, and thank you especially to Dr. Chow. Thank you.
Thank you very much, Richard, for the excellent